Welcome to everybody that is joining us. We'll get started in a few minutes. Please feel free to introduce yourself in the chat. Just make sure when you're using the chat to select everyone before. We have just a housekeeping slide up with a few things to remember. So your cameras and microphones are disabled. So please use the chat function or the Q&A function for questions, comments, or support. Again, be sure to select everyone when you're typing into the chat. At the end of the session, there will be 10 to 15 minutes for question and answer. If you're participating today to receive any CME or CU credit, you'll need to attend for 45 minutes or more to receive your certificate. All participants that would like to receive credit will also need to complete the evaluation survey after the session, which we will put in the chat and we will send via email as well after the training. And CME and CEU certificates are going to be sent out via email by May 8th, along with a link to the recording of today's session, the PowerPoint slides, and a list of related resources. And all of these materials will also be on our website in our BHIPP Resilience Break archive next week. So again, we'll get started in a few minutes, and please feel free to introduce yourself. Welcome, everyone. We'll get started in just a minute. Please feel free to introduce yourself in the chat while you're waiting. Just make sure to select everyone from the drop-down when you're typing into the chat. Okay, it is 12 o'clock, so we're going to get started. Welcome, everyone, and thank you so much for joining us today. My name is Lily Stavisky. I am the Outreach and Training Coordinator for BHIPP. I will be introducing our presenter for today and facilitating the Q&A at the end of the session. For those of you that may be unfamiliar with BHIPP, I just want to provide some information about our program. So Maryland Behavioral Health Integration in Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers and emergency medicine professionals to address and manage mental health concerns. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, telemental health services, and training and educational opportunities. The BHIP Warm Line is staffed by a team of child mental health specialists, and it's available Monday through Friday from 9 a.m. to 5 p.m. And we will place our phone number and our website in the chat for you. It is my pleasure to introduce today's BHIP Resilience Break, Strategies to Support Families Through Mandated Reporting in Pediatric Primary Care, presented by Dr. Jennifer Sirico. Dr. Jennifer Sirico is a clinical psychologist and assistant clinical professor specializing in child and adolescent trauma at the Center for Child and Family Traumatic Stress at Kennedy Krieger Institute and the Department of Psychiatry and Behavioral Sciences at Johns Hopkins University School of Medicine. Dr. Sirico provides clinical services for youth and families who have experienced trauma with a range of evidence-based interventions, including PCIT, TFCBT, and DBT. Dr. Sirico is a certified parent-child interaction therapy with an agency trainer and a child-adult relationship enhancement trainer. Dr. Sirico has developed an area of expertise in disseminating trauma-informed, culturally responsive, evidence-based care approaches with an emphasis on strategies for adults to better meet the needs of dysregulated youth who experience trauma. We are very grateful to have you here today, Dr. Sirico. Thank you so much for sharing your expertise with us during this session, and I will hand it over to you.
Okay, well, thank you all for being here on a Tuesday at what might be lunchtime for some of you. I'm going to go ahead and share my screen. We have a lot to cover in the next 45 minutes or so. Actually, we have almost an hour, which is good. So let me pull up these slides, and can everybody see that okay?
Yes, we can.
Okay, perfect. So as Lily so graciously introduced me, I'm Jennifer Sirico. I'm a psychologist at the Center for Child and Family Traumatic Stress. So primarily I am involved in doing clinical work with kids and their families who have experienced trauma. And I'm excited to be here and to partner with pediatric care providers just to get into the nitty-gritty. I have no disclosures, no potential conflict of interest or commercial support that's relevant to this program or presentation. And our goals today are to identify situations that require mandated reporting, describe trauma-informed, culturally responsive strategies to minimize harm during the mandated reporting process, including but not limited to transparency, engagement, and self-care, and then describe one example of how these strategies can be applied. And I can't see any of you. So at any point, if you have information or questions or comments, I don't know, Lily, if they can unmute or if it's just easiest to drop things in the chat.
Yeah, you can place any questions they have in the chat or Q&A function. And then at the end of the session, we'll take like 10 to 15 minutes to answer all the questions.
Okay, awesome. Thank you so much. You did
Mhm.
say the Q&A and I wasn't processing that. Okay, so that is what we're going to cover today. So let's start by thinking about situations that require mandated reporting. Now, everyone in the state of Maryland is a mandated reporter if you hear about something that happens to a child. Obviously, those of us who are working with children in medical settings or mental health settings are going to potentially have more opportunities for this reporting and are really held accountable, right? So all Maryland citizens should report suspected abuse or neglect to the local Department of Social Services or to a law enforcement agency. Ensuring the safety of Maryland's children is an obligation that's shared by all. And if you're a healthcare practitioner, educator, human service worker, or law enforcement officer, you're required by law to report both orally and in writing any suspected child abuse or neglect. Um, and so you report that to the local department in the jurisdiction where you believe the abuse or neglect is taking place. The oral report should be made immediately, and a mandated reporter is also expected to complete a written report within 48 hours of contact, which discloses the suspected abuse or neglect. We'll talk a little bit about what goes into those reports, as well as the kinds of situations that we're going to have to report. And I think it's important for us to just recognize that this feels like a really punitive system. And we're going to talk about some of the ways in which systemic barriers and oppression kind of factor into this system, and just how the awareness of that and how we handle these reports, again, through some of the strategies that I mentioned previously as our second learning objective, can help us show up in ways that allow us to support families through this process rather than have it feel like such a punitive kind of policing related experience. So let's think about the kind of things that we have to report. Oh, really rolling through that. So abuse means the physical or mental injury of a child that indicates that the child's health or welfare is being harmed or at substantial risk of being harmed. Typically, we are paying attention to someone in a caregiving role, right? So that could be a babysitter, that could be a daycare person, that could be, an aunt or uncle who's given the opportunity to take care of a child. Um, and that they have the opportunity to exercise authority over the child. And then they may or may not engage in either physical abuse, sexual abuse. Those are some of the examples of some of the situations that abuse can include. The things I'm going to focus on here are physical abuse, mental injury, and neglect. And then on the next slide, we'll talk a little bit more about sexual abuse and domestic minor sex trafficking. So when we are thinking about abuse, right, physical abuse involves Maryland's law specifically allows for reasonable corporal punishment or physical discipline. So parents can spank their children. Spanking is not something that is not allowed in the state of Maryland. They're absolutely allowed to spank their children. What distinguishes physical abuse is if the act results in injury and harm or injury and substantial risk of harm to a child's health and welfare, then the acts are no longer reasonable and must be reported as abuse. Okay, so we really want to think about those distinctions and pay attention to that. That's often why we'll ask follow-up questions around, like, did you have any injuries as a result? Was there any bruising, right? Those kinds of things to really help us understand and distinguish, did this child experience this as a physical abuse? And is this an ongoing concern? Does this put that child in substantial risk of harm? When we think about mental injury, that's defined as observable, identifiable, and substantial impairment of a child's mental or psychological ability to function caused by an intentional act or series of acts, regardless of whether there was an intent to hurt or harm the child, right? So mental injury is one of the most challenging reports to make. often because it is really difficult to define an observable, identifiable, and substantial impairment to mental and psychological abilities. While we might be able to see that, then having and being able to explain, like having the data, being able to support that it has been through an intentional act or series of acts, even if there wasn't an intent to harm, right? It sounds really confusing because it is. And so really paying attention to, are we seeing a lasting impact on this child? If in primary care, you're seeing these kids, once a year, twice a year, it's harder to tell if there's been a substantial impact. If you've seen a significant decline in functioning and you're starting to notice, like, this seems like a really substantial impairment in mental or psychological ability, and you're recognizing they're reporting this because my parent is doing this thing or this other caregiver is doing this thing. Now I'm, really anxious. I can't understand the world in the same ways. Then you might start to think about, okay, how can I document this? How can I make sense of this as mental injury? And then finally, neglect means the leaving of a child unattended or other failure to give proper care and attention to a child by any parent or other person who has permanent or temporary care or custody or responsibility for the supervision of the child under circumstances that indicate that the child's health or welfare is harmed or placed at substantial risk or harm, or mental injury to the child, or a substantial risk of mental injury, right? So again, a lot of times when we're thinking about neglect, when we're working with families where they're at significant risk of neglect, it's often because of poverty, right? And so we have to pay attention again to these systemic barriers and how can we be working towards problem solving and support and solutions, and so that we can avoid having to make reports of things like neglect, right? And that's hard to do, again, when you're seeing somebody once or twice a year. We know, though, that neglect is that intentional failure, right? So it really is distinguishing, is this family really struggling with poverty, right? Or is there an intentional failure to provide the necessary assistance and resources? It does not include the failure to provide necessary assistance and resources when the failure is due solely to a lack of financial resources or homelessness. So again, in those situations, we need to figure out, how can we support this family in accessing resources? What are the things that we can do to partner with this family? Because neglect is really about that intentional failure. There are so many times in which neglect gets reported when it really is about just not having the necessary assistance and resources. And so we want to work with families to help them access those resources when we can. One other thing of note related to neglect is that active caregiver substance abuse and exposure to domestic violence do not automatically require CPS reporting. These situations should trigger safety assessments and exploration of additional supports and services. So these are the kinds of things where we want to be paying attention to the current concerns, to the potential impact, and be really trying to support caregivers in accessing resources. When we think about sexual abuse and sexual molestation and exploitation, there we're thinking about sexual abuse as any act that involves sexual molestation and exploitation of a child by a parent or other person who has permanent or temporary care or custody or responsibility for supervision of the child. That includes by any household or family member, or by a person who, because of the person's position or occupation, exercises authority over the child. And then it includes any experience of sex trafficking of a child by any individual. To go further into the domestic minor sex trafficking, we know that human trafficking is a form of sexual abuse. It is defined as the recruitment, transportation, and harboring of an individual for commercial exploitation for sex or labor, right? So this is different than somebody making the choice to be a sex worker, right? Somebody is coercing them into engaging in sex work that they are not choosing to engage in, right? And so really thinking about those distinctions, and then going even further to recognize that we're talking about children here, right? So for individuals age 17 or younger, An offender does not even need to use force, fraud, or coercion for it to be deemed domestic minor sex trafficking. So any child under the age of 17 who is engaging in sex work and working for someone, that can be considered domestic minor sex trafficking. And those are things that need to be reported. Any disclosure of domestic minor sex trafficking requires a CPS report. And so any of these situations with sexual abuse or domestic minor sex trafficking need to be reported. So those are the kinds of things that we're going to report. All of this information is available on the Maryland Child Protective Services reporting suspected child abuse or neglect. So everything that I just shared is there, and we'll be sharing some resources to help you with that, including the form that you'll use. So how do we report? It is not our job to investigate allegations. And that's really, really important because a lot of times there's a lot of information that's required on these forms, right? You can see it all here, the name and home address, the present location of the child, the age, the names or ages of other children. There's all of this information that we're expected to report. And especially if you are only seeing the child once or twice a year, you're not always going to have all of that information. We want to make sure that we're engaging in these conversations in ways that help us get the information that we need to fill out the form and that don't result in us engaging in an investigation, if that makes sense. So really trying to partner with caregivers, and I'll talk a lot about how to do that, in having conversations that are really open about, okay, here's the information that's required. If we have it, great. If we don't, that's okay, right? One of the things that's really important is laying that foundation and letting families know the limits to confidentiality and when reports would need to be made, right? That helps them enter into the relationship with you. And I'll talk more about this so that when these things come up, when these conversations come up, it doesn't come as a surprise, right? And it makes it a little bit easier to engage in that partnership and say, okay, we have to make this call. It's not my job to investigate this. We're going to try and figure out as much of the information that we can for this form. And I don't need all of the facts to report, right? Other people will engage in that investigation. So what have experiences been for all of you in making reports? What does it feel like to make a CPS report? Any thoughts in the chat or in the Q&A? Okay, great. So Angela made the comment about in the past, I've reported severe abuse. The issue is CPS did not take it seriously. What can be done after? That is why often I think for providers across disciplines, it is so challenging to engage in this reporting process. One, because often we know it's treated like policing instead of like a partnership, instead of like a supportive response to a family in need, right? So that makes it really difficult. And then so many times we make the reports and they don't accept them, even when it feels like we're reporting something that is really severe and really significant, right? And so it is really hard to engage in this process. I think that that's one of the most important things. I was saying to somebody that I was doing this training today, and I was like, oh, this is like brutal. Who wants to talk about CPS reporting? And here I am doing that because it is important, right? Our goal is to keep children safe, right? And we want to be able to keep families safe and together. And so being able to have these partnerships and being able to have these conversations openly and create the space and the opportunity to have those conversations to help families access resources and support is what our goal is, right? And when we see children who are severely harmed, we want the systems in place to be able to follow through. What I found in those situations is that you have to be really persistent. And that's really hard if you're not seeing them actually like regularly. For me as a provider who's seeing families every week, right? It's a lot easier for me to be able to make a report every single week until finally they take it seriously. I did have one CPS worker tell me in a situation that that was very like significant, repeated, prolonged physical and sexual abuse. It had been reported multiple times. I had the CPS worker eventually say, put it in an email, which I was really shocked by. And that was the only way that they finally responded. And so I don't know if it was something like I don't know what it was in that situation that writing the email and writing things out outside of just the written documentation helped kind of push it along. But that was feedback that I once got from a CPS worker. Um, I see that somebody wrote, it depends on the justification in terms of how reporting go. I've heard the email tip as well. And sometimes I ask if there's a worker or supervisor assigned, and then I send an email. So that's definitely a way to do it. Often when you're making the report, it's really helpful and important to get the name of the person that you're making the report to. So that's a place where we can definitely then say, okay, can I also have your email address and direct phone number? Can I follow up with you? I'm, expecting to see this person again on this date. A lot of times they'll say no to some of that. And I think just trying to figure out how can I have some communication. Definitely if a caseworker is already assigned, then that's a great way to kind of engage in that ongoing communication with somebody. And then I see when encountering emotional abuse without physical or sexual abuse, how do we approach those situations? And those are complicated, right? Again, because a lot of times those are reports that you see it, you see the impact, and they're often not accepted. And so I think, again, it really does come to persistence. And a lot of us don't have the time or the energy to be able to be making these calls persistently. So it's also supporting the families and the caregivers and being able to, say, okay, here are the next steps. The next time, and whether it's the caregiver you're working with or somebody else that's supporting this child, potentially even contacting the school and having a conversation with the school if the parent approves that, right? If you can get some of those releases signed, then that also gives the potential for school to have more of that kind of oversight and to be paying attention to, are they seeing a significant decline in this child's functioning? Could they be making reports more consistently, right? So those kinds of things that can potentially be helpful. And then I see, Angela, your comment about watching someone several times commit physical and mental abuse and your kids witnessing it also. And it sounds like in that case, potentially, even though you reported this, you watched it, you said that there were multiple witnesses. My guess is that what you're saying is that potentially even those were not accepted. And again, in those situations, if there's other people around, if there's other people who can also make a report, definitely the more voices, the more reports made, the more likely they are to accept it. And it's unfortunate. I think that's again like why I was like, ugh, who wants to talk about this? Because you're in a situation that is uncomfortable. You are doing your best to protect a child. And often we don't feel like we're helping either because we know that the system is going to respond in a way that's not helpful, either by not doing anything or by doing something that feels really extreme and potentially detrimental to the family. Um, I know I certainly have really significant concerns about the systemic barriers and the systemic racism and oppression within these systems, right? And how certain families over time have consistently been the ones targeted. And so, really thinking about that distinction and that also kind of, I think, brings a lot of cause for alarm and concern in making these reports. Um, and then I am seeing some more things pop up in the chat. Is parental refusal to follow physician recommendations regarding treatment for a child with a severe eating disorder considered neglect? I think that not when we think about not following medical advice, especially for a child, that does seem like something that's worthy of reporting, especially because we know, especially with eating disorders, right, there is that potential for death as the result of a severe eating disorder, right? So when we look at the definition, then in that case, it is the intentional failure to provide necessary assistance and resources for the physical needs and mental health of a minor that creates substantial risk of harm to their health. So I would say absolutely, based on the definition, without a doubt, that would be something that would be reportable as neglect. Okay, so let's get into what we can do, right? Because the system is challenging and it puts us in situations that feel really difficult and overwhelming. And so, what can we do to be able to respond in ways that allow us to partner with families, that help families feel like we're engaging in connection and community and partnership rather than feel like they are being policed? So, one of the most important factors here is thinking about cultural humility. When we think about the three tenets of cultural humility, that includes lifelong learning and self reflection, institutional accountability, and mitigating power imbalances. So, when we think specifically about lifelong learning and self reflection, we're really thinking about doing that work independently, right? What are the things that we are doing to understand cultural differences, to understand systemic and racial oppression, right? We have to know that this is a lifelong commitment, right? We are never going to be able to know it all. That's actually why so many different disciplines have really shifted away from saying cultural competence because we can't possibly be competent about all cultures, about all identities, and especially about how each individual's identity intersects, right? Every single person has their own individualized identity that's made up of these different factors and characteristics, some of which are going to carry power and privilege, and some of which are going to be oppressed. And so we can't possibly know every person's lived experience. We have to commit ourselves to learning as much as we can and to having that be an ongoing process, right? To always be committed to learning, to intentionally seeking out diverse sources of information, to really making sure that we understand what anti-racism values look like and how to put those into action. Those are sort of daily choices that we make. And then being able to really focus on the institutional accountability, right? Many of us are working in systems, right? I'm talking a lot about like the social services system as being oppressive. We're also working in systems that have been oppressive or caused harm at different times, right? And so we need to acknowledge the racial and cultural oppression that occurs within the medical and mental health systems and have awareness of that and be able to do things that hold ourselves and our institutions accountable. I have one example is like you've seen a lot of pushback on DEI lately. We know that we're currently in a situation in which peaceful protests are being horribly disrupted, right? And so recognizing in those situations, instead of moving away from those kinds of efforts, how do we lean into those kinds of efforts to hold ourselves and our institutions accountable? What are the things that we can continue to do to push forward in creating change at an organizational level? And then in terms of mitigating power imbalances, right? As providers, we're always in the position of power. We might not feel it because we might be the lowest on the totem pole within our organization. And when we are interacting with a patient and with their family, we are the ones carrying the power in those situations. So again, it's important to hold on to that awareness of that, to acknowledge that. And one way to mitigate that, and you'll hear about this quite a bit as we continue talking today, is being able to offer options and give patients and their families a voice and choice in their decision making. So some of the things in terms of thinking about how do we carry cultural humility, right? From a culturally humble lens, we want to be aware of those systemic factors. That's part of that lifelong learning and commitment. So some of these factors that increase risk include these adverse childhood and community experiences that can occur both in the household, and you see some of those on this tree here, and can also occur in the community. You see those as the roots. And then you also see the ways in which the environment can all come together to cause these toxic stress environments. So, left unaddressed, toxic stress from ACEs harms children and families, organizations, systems, and communities, and reduces the ability of individuals and entities to respond to stressful events with resiliency. Research has shown that there are many ways to reduce and heal from toxic stress and build healthy and caring communities. And so that's a big part of what we want to be able to do. When we talk about families at risk, we mean families who, for whatever reason, might find it difficult to keep their children safe. A lot of these factors are factors that make it difficult for them to keep their children safe, right? And many of these things end up being mental health issues and major risk factors that can be associated with child abuse and neglect. So when we pull kind of all of those things that I was just talking about together, you can see how this expands upon the typical ACE pyramid. So if you've ever seen the ACE pyramid, I'm sure most of you have, right? At the bottom, it talks about historical trauma and intergenerational trauma, and then kind of builds up to having an adverse childhood experience, and then some of the outcomes related to adverse childhood experiences. Now, this kind of takes into account a little bit differently how, of course, that historical trauma is the foundation, right? That historical trauma, the intergenerational transmission of racism related stress in particular, right? It puts youth at risk before they're even born, right? And then you factor in those exposure risk factors. And we just looked at a lot of those on that last slide that showed us those environmental factors, those community factors, and those household factors. And then you can see how biopsychological vulnerability factors into that, gives you an increased likelihood for having those adverse childhood experiences, many of which are the kinds of things that you would be reporting, right, to Child Protective Services. And then thinking about, well, once that report is made, once you're aware of this potentially traumatic event for this child and their family system, then you have these additional factors, right? You still have those racism-informed social conditions, and now potentially this family is involved in agencies and systems that have consistently been harmful to people who look like them. And you also have that increased biopsychological vulnerability, which results in sort of those increased mental health outcomes. So you can see how this kind of pulls together everything that we've just been talking about, hopefully. So what are the things that we can do in terms of trauma-informed care? These are the SAMHSA's 4 R's of trauma-informed care: realizing the widespread impact of trauma and understanding potential plans for recovery, recognizing signs and symptoms of trauma in clients, families, staff, and others involved in the system, responding by integrating knowledge about trauma into policies, procedures, and practices, and resisting, so seeking to actively resist re-traumatization. So in reporting, we first need to realize the impact of reporting and how that can be traumatic for a family system in a variety of different ways, right? The child trauma that the report might be based on could have a significant impact, right? There's the potential for CPS involvement that may also have a lasting impact on the family system, potentially resulting in either a period of separation or a prolonged separation within the family system, right? So we want to really be thinking about, okay, we are working in systems where we have to be super aware of what does trauma look like and what are the plans for recovery. So if we're seeing families who are experiencing a higher level of risk for some of these concerns, how do we support them before we get to the point when we need to be making that CPS report, right? How do we support them in accessing resources and accessing other kinds of services? Maybe it's caregiver mental health services. Maybe it's access to other kinds of social services for financial resources, right? Really thinking about what we can do and how can we refer families to case management or other kinds of resources to get help in those areas. Then we have to recognize, right, the signs and symptoms of trauma. So, what are we paying attention to? We really need to be noticing if a child is reporting something that happened and you're like, you're then sort of on edge. I'm going to have to make a report about this. We want to slow ourselves down and pay attention to how's the kid talking about this, right? What are they saying about their experience? Is this different than how they normally talk about things in your past experiences with them? If this is sort of a patient that you have seen throughout, their life up to this point. Even if not, does this feel like as they're talking about this, their tone of voice has shifted, right? They might be suddenly really avoidant. They might be showing some signs of re-experiencing. There might be changes in their mood. There might be some clear kind of indications that this has resulted in more significant changes in how they think about the world. Maybe they're saying things like, I'll never be able to trust anybody, or the world is really dangerous, right? For some kids, that might be really true about their lived experience. And that also probably means that they have some significant internalized trauma symptoms. And so, really thinking about, do they seem really hyper aroused and triggered as they're talking about that? So that we can be recognizing that all of those are signs and symptoms that this has impacted this child in a traumatic way, right? There are all of these different adverse childhood experiences that people can experience. It's a question of whether or not that child actually then has a traumatic response to that. And so that's what we want to be recognizing, and that's what we want to be paying attention to here. And then how do we respond, right? How can we integrate the knowledge about trauma into our policies, procedures, and practices? We're not going to change the CPS system. And what are the changes that we can make within our organizations to be able to say, okay, we know that we need some case management, right? Our practice needs to have case management so that when we see families coming in with this higher level of need, that we can get ahead of those potential risk factors, that we can be connecting them to resources and services, and that doesn't necessarily have to fall on me as a pediatric care provider who's only seeing them once a year, right? So really thinking about what can you do within your organization to build policies and procedures and practices that can, again, get ahead of the to engage in CPS reporting. And then finally, how do we resist to actively re-traumatize, right? So we need to be working on, again, building those relationships and having that awareness and carrying that awareness with us, mitigating those power imbalances, right? And really thinking about, okay, this is potentially anytime we're making a call, this is potentially a traumatic thing that we are doing, right? And so what do we do to resist that re-traumatization in that process? Part of what we can do is take those four key elements and think about the principles, right? So first, we want to create a sense of safety, right? These are the 6 guiding principles to a trauma-informed approach. These were developed by the CDC's Office of Readiness and Response in collaboration with SAMHSA's National Center for Trauma-Informed Care. And this is really about increasing responder awareness of the impact that trauma can have in the settings in which we work. So thinking about the sense of safety, right? What are we doing in our everyday practice that helps families who come in feel safe? Right? And then how are we engaging in conversations in a way that build trust and create transparency? Like I said earlier, really laying that foundation up front and reminding families, potentially even at each visit, of the limits of confidentiality and what will happen in those situations. Being transparent is always going to help. It is an anti-racism value, right? So again, if we want to be upholding anti-racism values in the work that we're doing, transparency is an amazing way to do that, really letting people know what to expect and what will happen as a result, right? So that trustworthiness and that transparency, then having opportunities for peer support, right? And so that's not just limited to families that are coming in and seeking care, it's also among the staff, right? It's with each other. And so, how do we make sure that people feel supported, that there's a sense of community? And then how are we collaborating, right? How are we working together towards shared goals? And so part of that is, again, comes back to that idea of being able to have teams working together to support families and working together to support each other. And then I mentioned it before, right? That idea of voice and choice that helps people feel like they have some sense of power. It does mitigate those power imbalances rather than somebody just saying, here's what we're doing, here's how this is going to go, this is the treatment, right? Often as medical providers, that is the expectation. I was doing a training recently with SLPs and speech and language practitioners, and they were saying that, you know, especially in early career, the expectation is that you have a solution. And if you don't have a solution, then you feel like you're not doing your job right. And that's fair. I totally get that. And sometimes just coming to a family with a solution doesn't allow them to feel heard. It doesn't give them the opportunity to feel like they're making a choice, and that diminishes their sense of power and control in that situation. So how do we create opportunities for that? And then how do we, you know, increase our awareness of the cultural, historical, and gender issues? That's why I started there, because that piece is so important to think about, you know, those power imbalances, that structural and systemic oppression, and how that shows up in our interactions. To be trauma informed, right, we also have to be anti-racist and anti-oppressive. So what are some strategies that we can use? There are a lot of things up here. One of the first things, right, is creating that physically safe and welcoming environment. Do you feel safe and comfortable when you show up at work, right? How are people going to feel coming in? Are there toys for kids to play with? Are there, you know, things for parents to look at so that they can feel calm? A lot of times going into appointments is stressful, right? And so thinking about what are the things we can do to create a calm, physically safe and welcoming environment. Then making sure that families know what the expectations are, right? Sometimes that's signage on the wall, just kind of putting up there what are expectations. Often, if there are ways to partner with the community to kind of think about what would agreements be, right, that we could have on the wall so that people know what the expectations are. When you're working with children, it's really helpful to have an awareness of what some logical consequences would be, right? Oftentimes, when we are witnessing situations in our offices where parents are potentially becoming aggressive, it's because they are in a vulnerable state. They're stressed out about being at the appointment. They were maybe rushing around to get there, right? And then their child's not behaving in the way that they want. And so then they're going hands-on because they feel this added pressure to control their child. So how can we support and have an environment that already has some logical consequences in place, right? Is there somebody who is available if the parent wants to come in and give you some information to keep an eye on the child, right? What are some things we can do to kind of say, okay, well, here, what we do is that there's the space that they can go and sit in, and there's some toys that they can play with so that they can get comfortable, right? I know that you all are in time pressured situations that might not be feasible, and thinking about what are some of the ways that you can build some of these strategies in. We're going to talk a little bit more about some communication skills that can be helpful. Really trying to pay attention to behavior, both caregiver behavior and child behavior and our own behavior through a trauma lens, like really recognizing what are we noticing about ourselves? What are we noticing about, you know, how this child is interacting? Why might they be engaging in some of this aggressive play? Why might this caregiver be so frustrated and overwhelmed or talking to their child in this way that doesn't feel very safe, right? Thinking about maybe this is how they were parented, right? So what can we do to support them rather than jumping to This might be, a cause for a report. Being aware of potential trauma reminders. So, if other people are yelling and screaming in the office, if there's other things that people can hear, those kinds of things. So just having that awareness and trying to manage some of those things. Again, coming back to that voice and choice, right? Providing options and choices. Increasing opportunities for support. We've kind of talked about this a bunch already. Like, are there opportunities for case management, for access to other resources? Can we have a resource list that's available for families that we can be providing them? How do we know what are challenging times when we know we're working with families that have experienced loss, right? Holidays, which for lots of people are like a fun and great time, for people who have experienced loss recently, that can be a really challenging time. So being sensitive to that and aware of those kinds of things. Being able to provide warnings for different changes and transitions. If your office is kind of going through their processes differently, helping families know in advance that things are going to look different the next time that they come in, right? Really making sure that families have the information about what to expect. And then empathy and validation, and we'll talk a little bit more about that. So what are some of the communication skills? We want to be able to listen. We want to be able to summarize what people are saying. We can show that we're listening through those nonverbal cues, through nodding, through saying, yep, I hear you, right? At the end, if a family is telling you this is the concern I'm coming in for, being able to pull that together and summarize that. Being able to show empathy. I'll show you a quick video on the next slide about the difference between sympathy and empathy, and then taking it to the next level and validating. And I'll follow up from that video with some examples of validation. And once somebody feels seen and heard, it's a lot easier to get to offering solutions. They're going to be much more interested in hearing those solutions that you have. And then from there, we can engage our peers and our colleagues in any of that problem solving that we need to do to be able to make sure that we are collaborating care and meeting this family's needs. So let's see if this will play. Okay, great.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Okay, so I love that video because I think it summarizes empathy beautifully. There's a ton of research to show how important empathy and compassion are within medical systems and that it truly changes the outcomes, both in terms of the health outcomes as well as the sense of community and things like that. So Compassionomics is a great book that talks about that, but there are lots of really great resources related to the importance of empathy and compassion in healthcare and the impact on the outcomes. To go beyond that, right? Being able to validate, especially being able to validate a caregiver who is talking about the stressors of parenting, who is talking about the harm that they may have caused their child. You might not agree with it. Validation is about finding the kernel of truth in the person's feelings, thoughts, or reactions. It's the ability to let the person know that they're understood and being able to say, it makes sense that, or of course you are, right? It's taking it to that next level. And I am aware of the time, so I'm going to try and move us forward a little bit here. So knowing the history and the increased risk for certain families, particularly Black and Brown families and Indigenous families and child welfare, we need to really increase the transparency in the process. So really thinking about how can we be aware of the potential harm that comes out of it? How can we be responding in these more trauma-informed ways so that we can really be promoting the well-being of children and strengthening families to support children's development. Most of us went into a field to serve children because we wanted to help them and we wanted to keep them safe and be useful and beneficial in their development, right? And so really thinking about what are the things that we can do to continue to protect children and strengthen families. So I've talked about some strategies and, I had one more learning objective here, which was to describe an example of how these strategies can be applied. So imagine that you've developed a good relationship with a patient in your pediatric primary care setting. You notice a bruise on their arm and you ask them about it. Their parent has stepped out and they say that their parent's partner grabbed their arm very hard and left the bruise. So this is the situation. This is like an easier one to navigate, right? Because it's not a kid saying that their parent did it. And it is, it's a kind of physical abuse situation. Those feel often more straightforward. None of reporting about any of these situations is easy, right? And some of them feel more straightforward than others. So what's your next step, right? You know that you are going to have to make a report. So how do you follow through on some of those principles that we just talked about to do that in a way that feels meaningful and productive and trauma informed and culturally humble, right? So how would you use the strategies discussed to partner with the child? How would you engage the parent in the process and partner with them? And what do you anticipate the outcome would be? So we have these different things that we're going to think about what to do, right? So what's your next step? You know that you have to make a report. So you want to be able to use those communication skills to be able to talk to the family about those next steps, right? We talked a lot about transparency and safety, right? And so hopefully you've already laid the foundation that this would be part of the next steps, right? And then you are going to have a conversation with the child where you listen to them, you reflect, you empathize with them, and then you let them know, okay, here's what we're going to have to do. As you know, we've talked before about how when you report that somebody's hurt you, that we need to, follow through on these steps and let these other organizations know so that they can keep you safe, right? And so I'm hearing, Angela, thank you for participating. Get more information, right? So is the child afraid? Does this happen often, right? Figuring out how to, I love this point, which is sometimes parents and caregivers grab a child to get them away from a harmful situation. That definitely does happen. So you'd want to know, what were the circumstances? How did this happen? Is this something that's happened before? Was it intentional, right? Those kinds of things. So definitely using those listening skills, using those skills of reflection, right? And then being able to get some more information, right? And then you would do that. Those are some of the ways that you would partner with the child. And then you would want to engage the parent in this situation for sure. I think most of the time, even when I'm making a report on the parent who is there, I want them to be a part of that process. I want them to be aware that it's happening, and I want to get their side of it as much as possible, so that, exactly to Angela's point, right? If I'm not engaging the parent and I'm only getting the kid who's saying, they hurt me, they left a bruise on me, then I'm making a report that might be totally one-sided. I don't want that child to still get harmed. And if the parent was really trying to do something to keep them safe, then I want that to be part of the report. And I want the caregiver to feel like I have been empathetic and validating with them as well, right? I want to be able to make sure that, if the child was acting out, I'm able to talk about it. Well, maybe part of this is because they were feeling scared, right? And be able to help families start to have some more of that understanding. Also being aware of, like, this could be a really traumatic situation for a family. Maybe they've had experiences with policing or experiences with CPS before. Maybe that parent or caregiver has their own history of being in the foster care system. So really being mindful about, I know that this is really scary. I know that this can potentially feel really traumatic. And so thinking about being really honest and transparent about that, knowing that this is going to be something that's challenging, and really trying to use that empathy and validation. And hopefully in this kind of situation, the outcome would be that the parent partners with you and is willing to make the report, and you all can make some decisions about next steps for safety, right? So here are the references. I know that some of that was rushed through. I'm happy to talk more about other clinical examples. I know that there was one question in the Q&A from Regina. I once reported about a 19-year-old ex-patient of mine based on her sister's account of parental abuse, but the patient did not directly tell you about the abuse. You can make a report that's through someone else. If somebody else shared that information and you are concerned that someone is in danger, then absolutely. And it's certainly also a situation where you would want to, again, kind of partner with the family, get more information, see what else you can do to have a better understanding of what happened. But absolutely, there's no harm in reporting when you're concerned about a child or adolescent or even young adult is potentially in danger, or that sibling would be also in ongoing danger as a result.
If anybody else has any other questions, please feel free to place them in the chat or the Q&A function. We have a couple minutes left.
I definitely say, I started to mention this before, but certainly kind of recognizing that different kinds of reports come with different complexities. When we think about making sexual abuse reports, often we're making them against another family member, and that can result in pretty significant disruptions and impacts on sort of the larger family system and the family functioning. And so being able to kind of really, as knowing, asking questions about the support system, gathering information about what families think the impact could be, and helping them access resources as soon as possible, especially if we know that it's likely to have a pretty lasting impact, which many of these reports do result in those lasting impacts. Okay, references and thank you. Thank you all for being here. Feel free to get in touch with me or with the BHIPP team for any more information or follow-up.
Thank you so much for this wonderful presentation, Dr. Sirico, and to everybody that participated in today's session. We will be sending the recording of today's session, the PowerPoint slides, and a list of related resources out to you all via email, and it will also be available on our website next week. We will send all CME and CEU certificates to participants by May 8th, but please remember to take the survey as you exit, which is just placed in the chat, as this is required if you'd like to receive a CME or CEU certificate. And we'll also send it out to you via email as well, so you have that. And stay tuned for any future BHIPP trainings by following us on Facebook, LinkedIn, and Twitter. And thank you so much again, everybody, and I hope everyone has a great rest of their day. Thank you.